All right, good morning, good afternoon, good evening, wherever you are in the world. I'm not sitting in a library with rich mahogany wood or leather-bound books, and that this is just my casual backdrop here, talking with the one and only Dan Lorenz. I've been gushing over Dan's work for years. I've admired him from afar on social media and some of the things that he shares, and he's been nice enough to join us on the ACL Hub tonight to talk shop on ACL. So Dan, welcome, and yeah, thanks for coming along for a chat.
Mick, so great to see you and meet you for the first time online, and thank you for the gracious introduction. I'm really happy to be here and excited to talk shop.
Yeah, me too, mate. Thank you, thank you. It's yeah, like I said, I've just watched, what it's now not called Twitter, but for a long time I've sort of followed some of the things that you share, and obviously read some of your academic papers and what you publish as well. So I'm grateful for people like you trying to push the field further. So yeah, to be able to have the opportunity to talk, I'm grateful. And for those that may not have come across Dan, I don't want to butcher your bio. I don't want to sort of get things
Uh,
wrong. So I might just give people. I might let you have a quick minute or so just to sort of explain to people your background, where you worked, and where you currently work, and a little bit of maybe a 60-second bio of who Dan Lorenz is.
yeah, very briefly, I'm a native of suburban Chicago in Illinois, and I got my PT degree back in 2001 from Grand Valley State in Michigan. I got a DPT at a school down in Florida in 2009. I did the Duke University Sports Physical Therapy Fellowship from 2004 to 2005. And then in 2005, I got hired by the Kansas City Chiefs in the National Football League to be an assistant athletic trainer and physical therapist. I did that for a couple of years. I had my own practice for 7 years. We built it eventually to three clinics, and now I've had the privilege of speaking at a lot of meetings nationally. I spoke for the first time in Scotland last year on ACLs at
Oh,
the
nice.
European College of Sports Science meetings. That was really exciting for me. And now I'm currently the director of sports medicine at Lawrence Memorial Hospital in Ortho, Kansas, in Lawrence, Kansas. Which is
Yeah,
about an hour outside of Kansas City, Missouri. So
yeah.
I think I may have done that in under 60 seconds, I hope.
You did a remarkable job. I'd be still going after talking. We're a bit slower here in Australia, and my country upbringing is probably just sort of slows things down. So, no, well done, mate. That was very, very good. It's kind of like that. That bio is remarkable. Like you've got such an extensive history. You've got the nice blend of both athletic trainer. We don't have athletic trainers here in Australia. We're kind of, it's either strength and conditioning, exercise physiology, personal trainer, all kind of grouped into this exercise professional world. And then we've got the physiotherapist or the physical therapist here. So, but I do understand athletic trainers are a nice blend of strength and conditioning coaches and PTs, and they're kind of like meet in the middle a little bit. But that background with your physio and clinic owner, like there's a lot of great hats to sort of wear. And, over the last 20, 30 years, I'm sure you've sort of picked up a lot of things along the way. I've read a lot about you and wanting to bridge the gap. And I probably just wanted to start off before we dive into the ACL world is, I guess your why in, being so actively involved, and I guess your why in sharing things on ACLs on social media, and, I guess in a way, like, what's the gap effectively, like from
Yeah.
what you've seen in your years of clinical practice that we need to try and bridge?
Really my interest started in strength conditioning before all of it. I started out as a power lifter like in seventh grade. So I was kind of a gym rat. So I had a pretty good, knowledge of the weight room. And then as I got into PT school and I went to courses and stuff, I started going to national meetings and things over here in the US. And, I would hear people speak and talk about like late stage programming, that were mostly PTs. And it was very vague, and they would say like, give you an example, like there was somebody with late stage rehab progression of an ACL, and it was like doing single leg squats on a BOSU. And I don't have a problem with a BOSU, I don't have a problem with single leg squats, but that's not late stage rehab, and I would keep seeing things like this, and that is not preparing the athlete for the rigors and the high demands of competition. And you have young clinicians that are impressionable at those meetings, and they're thinking this is the way to do it, and no wonder why our retear rates are what they are. So really what happened there then is was getting involved in the American Academy of Sports Physical Therapy. At the time it was a sports physical therapy section, And I started talking to some of their leadership, and they're like, you should really start a sports performance enhancement special interest group. So I did. We got one
Mm.
going, and really just tried to disseminate information about a higher level strength conditioning and performance enhancement in those terminal phases of rehab. So that's really what it was to try and I don't know how it is in Australia, but like, I would go to National Strength and Conditioning Association meetings here in the US, and I was always impressed with how detailed and specific strength coaches were with their programming. The sets, the reps, the load, the intensity, things like that. Like most physical therapy conferences I was going to, the programming was very vague. It would say start plyometrics. What does that mean? And we just weren't very good at it. So anyway, hopefully it wasn't a very long-winded answer to your question, but that's really where I guess I don't want to say I was the first one, but certainly somebody that was trying to start that conversation.
Yeah, no, great, and that's great background because I think we here in Australia we're kind of we've got a unique ability, I guess, compared to maybe some other regions around the world where we've got a lot of autonomy in what we do. We don't get told what to do by an orthopedic surgeon so much. Like we don't get a list of things that we need to do. Like we actually have the great respect within our peers, our medical peers, to take a case on and do it as we wish. There'll be some surgeons that'll have a protocol, and that's fine. But we do, we're a primary care health professional where we can take a person directly off the street, assess them, diagnose them, treat them, and manage them. But we are certainly limited in a way with our clinical practice is often limited by our four walls. There's not many clinics that have got the vast spaces where I've seen some wonderful
Yeah.
facilities in the US. You've probably got one yourself. And through Europe, we've got great centers with great space, great gym equipment, and really strong multidisciplinary teams where you've got physios working closely alongside exercise professionals and sports medicine doctors, that kind of stuff. We probably don't have that same extent here in Australia outside of a few places in big cities like Sydney, Melbourne, Brisbane, Adelaide, Perth. You'll have maybe a couple of centres like that. But yeah, that kind of leaves a big chunk of our population that do get I guess ACL rehab really well done through the early to middle stages, but that late stage is often that glaring gap or the we all kind of need better. And I think that would probably be similar stories across the globe.
It
Yeah,
is. I don't know how PT education is or physio education is in Australia, but in the US they make you a generalist, right? Where you can see anyone from an elderly person, inpatient rehab, pediatrics, neuro, and a little bit of orthopedics and sports. Like you really have to really seek out extra education on this to really learn some of those principles a little bit better.
yeah.
So I definitely there's a gap in education here, and we're I guess in a sense myself and a number of other colleagues have tried to fill that gap.
Yeah, you're right, and that's the same thing. And I think that's the beauty of education. Like we know that when you come out as a physio or a physical therapist, you've got the skills to handle a patient, but there's still a lot of lifelong learning to go, and you'll be able to manage them pretty well. But once again, we are limited with what we can teach you in the late stage, and I'm sure that the universities are very limited in what they can teach in the late stage of ACL rehab, but that's where people like yourself and some other great clinicians around the world that are trying to sort of change that and make that late stage because yeah yeah I scratch my head sometimes similar to you like when you see late stage rehab being Bosu ball stuff or still jumping and landing stuff or better you might even get some decent weight room activity being but we really need to bring that and get that onto the field and really get people on the court and really start imposing the demands that are getting them closer to sport rather than just looking good and fancy in the gym. Um, well, let's kick off into probably some of the early stage stuff, Dan. Like, well, in your early weeks, we'll sort of try and cover the spectrum from early through to late, and we'll try and get an idea of how you manage ACLs. But in those first few weeks after ACL surgery, I guess, how do you go about trying to, I guess, get on top of that pain, swelling? Like, what are your kind of key tips or um, uh, yeah, non-negotiables that you need to go after as a clinician to really set them up for a better transition through those early weeks through to the mid stage. Yeah, have you got any words of advice and wisdom?
Yeah, for sure. This is a multi-layered answer. I think, and first of all, the knee, we got to have a quiet knee. It's got to calm down as best we can. Now, sometimes we may be battling a significant cartilage injury down to the subchondral bone that leads to an elevated amount of effusion, or we're assuming they don't have any other injuries or other surgeries gone along with it. But, we got to have a quiet knee because that's just going to inhibit the quad. We've got to get extension as soon as possible. I emphasize that, it's very easy to prescribe a number of exercises that they ultimately need. But if you look at the data on home exercises, like the sweet spot is between 3 and 5, more closer to the 3 side, right? So I do a lot of extension. I mean, from the Paulus paper in AJSM, I think 1986 was really the seminal paper for telling us how imperative it was to get extension in the early phases. So control of pain, control of fusion, get extension as soon as possible. Get that quad. My quad algorithm is always: can they initiate a contraction? Yes or no. Can they sustain a contraction? Yes or no. And then can they do a straight leg raise without a quad leg? Like those, I'm not saying they're able to do that right away, but that's the decision you have to do, whether it's an ACL or a total knee. So,
Mhm.
and then obviously getting motion back as I don't want to say quickly, but you want to get them moving. I mean, I say it to patients all the time: motion's lotion. It's such a cliche, but there's some truth to that. I mean, it provides lubrication and nutrition to the joint to move it. So, um, I think in those phases too, it's just imperative to tell people, like, don't go to a concert and stand for 5 hours, or don't go to the soccer game where you're climbing up, hundreds of
Yeah.
stairs, and then you're sitting in a cramped seat. And that's the kind of stuff you have to avoid in those early phases, because otherwise you will have a very angry knee, and it's just going to inhibit your process. So any of the modalities that are useful in those early phases to help out with that arthrogenic muscle inhibition, which, as I'm not sure who your clientele is listening to these kind of things, but basically it's a fancy term for the nervous system shuts down the knee, and we got to figure out a way to get the muscles going again. There's lots of different techniques for that. So I think, much like you, I'd be curious if you have anything different to what I said there, but I'd say in the early
No.
phases, that's where I'm hanging my hat.
Yeah, absolutely, and yeah, it was very broad, and so sorry to
Yeah.
leave you hanging. But yeah, it's the same principles apply in my book too. I love your algorithm. I think that's a really, like, inherently that's what I do. But I love, how simple that 3 step process is, which I think a lot of, vast majority of people listening and watching this are in our early career stages of learning. So yeah, they'll probably take that little 3 step algorithm away quite nicely, which I think is beautiful. But yeah, attacking pain, attacking swelling, however way possible you can do it. Obviously, cryotherapy is a really good one. Any kind of elevation, swelling control. I find that if you
Yeah,
attack the swelling control, then a lot of things will happen inherently after that. You reduce the swelling, you reduce the pain, you increase the ability for the quads to contract, you increase the range of movement, and all of a sudden, without overthinking what you need to do, it's like, all right, I'm just going to attack this swelling, and all these, beautiful things happen on the back of that. So,
for
um,
sure.
yeah, it's very, very
And we
simple.
have so many tools at our disposal to use. Like for the sensory side, you can ice the joint, not the muscle. You could do
Yep.
tens. You could do vibration. And then on the motor side, you could do. I love muscle stim. Like, I have my patients buy home units.
Yes.
Uh, I just think it's imperative that they do that as soon as possible. You could use. I love biofeedback. We have a biofeedback unit, because that gives a more visual idea, I think, to the patient how hard they have to work.
Yep.
Like, I don't think until you put that on, they really realize how hard they have to squeeze, right? So
Yep.
those are, again, a few of the motor ways to help out with that too in those early phases.
Yep, agreed. Funny you mentioned the don't go to the concert in the first few weeks. I had a patient maybe last year when Taylor Swift was getting around the world, and yeah, she was only maybe 2 or 3 weeks post-op, and she had a Taylor Swift concert, and she went down to Melbourne and got up on her feet and danced the night away. Came back, noticeably swollen, and she was kind of wondering why. And I was like, well, we did talk about the hangover that you'll get not just in the brain and the head, but the knee hangover that you'll experience also too after Taylor Swift. So yeah, it happens. It
Yeah.
happens. What
100%.
what about BFR? Like I've heard you mention BFR quite a bit over the time. Is that one of your tools in those early stages? Like yeah, what's your kind of approach to BFR in those first few weeks to the first couple of months post-op?
Yeah, good question. The operative word there you said was tool. Like anything
Mm,
else, biofeedback's a tool, muscle stim is a tool, ice is a tool, right? For me, it's really, I think. And I would say even for some other diagnoses, I specifically think for me personally, I think for cartilage injuries of the knee, like I'm not sure if you're doing them as much in Australia, but the Macy's, the Macy's and the Oates procedures and things of that nature where you can't really load them and close chain and open, frankly, for like 12 weeks with
yes.
any kind of substantive load. So I really, really like it as a great adjunct to increase muscle strength and hypertrophy in those early phases when loading might not be tolerated or indicated, depending on the procedure that they had. There's definitely a lot of debate about this, and certainly there's people that could take me to task on this. I've always waited for a couple weeks, like let the wounds close and let the knee calm down from a pain standpoint. Yes, there's studies that show BFR, has analgesic effect, but people are really struggling a lot of times in those early phases, and that's a noxious stimulus in a lot of ways. And I don't know. I always kind of say with that, look, if you want to use it, fine. I'm not going to say not to, but I also always say, where's the fire? Like,
Yeah.
what is waiting 14 days for the wounds to close and the swelling to come down a bit and them to feel better about things before you introduce, particularly if it's somebody that you just met,
Yeah.
and you're building that rapport, and then all of a sudden you're giving them this very irritable thing. I don't, in my experience, again, some people might think I'm crazy. That's fine. You practice how you see fit, and if you turn off your podcast because of me, sorry if you lost some listeners. But I don't know. For me, I just there's a time and a place, and as soon as I can tolerate it, I'm gonna try it. But in those early phases, first couple weeks, it's just not on my radar yet.
Yeah, I think that's a really good stand. I actually don't use BFR very much at all, to be honest. If I was going to use it, I certainly wouldn't. I sit in line with you. I wouldn't be using it in probably the first 2 or 3 weeks for probably a few different reasons. I know for me, it's more of a safety concern. They've just had surgery. They're already at a fairly high clotting risk. Yes, most people get TED stockings. They get anticoagulants and they have a few things that kind of mitigate that risk, but there's always something there that can go wrong. But agree, there's just always there's a lot of other things they probably could be doing that'll yield a better bang for buck, so to speak. And I always sort of sit with if I'm going to do this in the clinic with my patient twice a week. For some of my patients can't afford to come back in twice a week. They're not covered by insurance or whatever. So if they need supervision to do BFR, I just sort of think about, what are some better yielding results in that first month and showing them how to, you know, I guess maybe take a TENS unit home or a stim unit home might be a better way to go, or showing them how to use a cryo cuff properly, or showing them isometrics, or I just think there's some probably better ways to go after that first few weeks. And then if we can get the quads recruiting pretty well, it's like, well, let's sort of start there. I think in hindsight, I probably had maybe a dozen people in the past where I thought I probably should have started a bit earlier than what I did. But if we go at them sensibly from the outset and we hit those big at home things that they can do, I find that works pretty well for me in my practice anyway. So
It does, and we've been able to get people strong for and hypertrophy for a number of
yeah,
years training the normal way.
yeah, yeah,
To me, it's a nice tool. I don't do it for everybody. I certainly recommend home units if people really like it. Some people do it and they just feel because they're exhausted when it's done, they really feel like they got something out of the workout, more so.
yeah,
I don't know. There's that mental piece of, the muscle's fried. I did good work, right? So there's
yes,
some people and those people, hey, here's a different price points. They'll of course know what it's, tons of education, what it's supposed to feel like, what it's not supposed to feel like.
yeah,
More is not necessarily better on this, those kind of things. So, like anything else, if you spend time teaching people, they do well with it on their own. But again, there's not that many patients I'm suggesting that they should get it at home. And again, I don't even use it on everybody, to be very clear. So
Yeah,
the usual stuff works pretty well. But
yeah,
in somebody that's really struggling, especially if they can't tolerate higher loads, or again, if they have a concomitant procedure that
yeah.
doesn't allow us to load, then I'll use it, fairly regularly.
Yeah, no, great tips there. That's excellent. Now the big one about open chain exercise. Where do you sit with these boundaries in your practice? It's
Oh gosh.
I love asking this question to all my
Yeah.
colleagues. And I think we all sort of sing from the same hymn sheet, but yeah, I'd love to get your view.
I think we do now. When I was coming up, and this is something I impart on young clinicians a lot. That's why it's so imperative to read the literature and go to meetings and understand what the current state of affairs is. I mean, there's been a massive shift in the understanding of the safety of open chain exercises. When I was coming up, you did
Yep,
not do this
yep,
prior to week 12 at least, because you would stretch the graft. And there was all those studies showing that the weight at the distally and doing open chain would stretch the graft, and the strain in the graft was too high. And really a number of studies in the last 10 years has just refuted that completely.
yep,
So yeah, it took me some time because you're nervous because you were brought up one way to not do that. So long and short of it is, I will typically start with a 90 to 45 with stim within the first
yep,
2 weeks.
yep,
I'll make sure they're not having any irritability. If they're not having any irritability, I'm going to go full arc, no resistance with stim within the first 4 weeks, 90 to 0. Uh, I will start loading it with BFR in from 2 weeks and beyond, using cuff weights and things of that nature. But yeah, I've certainly loaded them a lot sooner in open chain. But I'm always monitoring. Are they swollen? I'm not saying that's why they're swollen, but also too graft choice matters on that. I think a patellar tendon graft can get very angry doing that. So I'm very careful with those, more so than I am with, say, a hamstring graft or sometimes a quad tendon can get irritated. But a lot of times they lack that terminal extension anyway, so it's hard to even do those. So
yes.
again, everybody, you got to again treat everybody as an individual and the graft that they had and what their symptoms are and how their knee is responding.
Yeah, yeah, I agree. I've definitely come, full 180 on it. Like you, I did my training in sort of the mid 2000s, late 2000s, and it was very much, yeah, don't do open chain exercise at all. And even the first 5 years as a clinician, my mentors, orthopedic surgeons that I worked with and their protocols were just no open chain. But you're right, in the last 10 years, there's been a really nice influx of guidelines and now in recent years, a couple of papers that have, there weren't any randomized control trials in this area or even case studies or case series work for over a decade. There was a bit in the 90s and early 2000s, but then it kind of went quiet after Fukuda in 2013, and it's just now been a little bit of a resurgence in the last 10 years. So it's
Yeah,
nice to feel comfortable doing it, and I certainly sleep a lot better at night with the support of the guidelines, and but also seeing the improvements that your patients are getting. Like every
yeah,
person that you're working, you're just building this kind of knowledge bank and recognition that you aren't causing any harm, especially when you've taken a few patients from start to finish and you can see them again 12 months, 18 months down the track, and there is no laxity at all between their legs. They're functioning really well. And it's like, you know what, there's something about this open chain work that seems to be doing a pretty good job. So obviously with a lot of other things tied into it. But yeah, no, it's for me, I've really come around to it a lot in the last, 5 to 10 years. And I've seen the benefits of it with my patients, and my approach will be very similar to yours. So, um,
Mhm.
no, that's good.
Yeah. I
Good,
think
good.
we have to get away from that idea. I don't know what it was like in Australia, but there was this trend for a while to train movements, not muscles. And
Yep,
you play sports on your feet. You need to train in closed chain. And but if there's a weak link in the chain, which inevitably is always the quads after this
yep,
surgery, you have to address that. I mean, why we have to be black or white and why it's not a both and. it doesn't have to be either or. So it is, like I said, it's imperative that it's a both and. You do closed and open chain stuff, and there's really no reason why you shouldn't. And the evidence actually would be against you picking just closed chain at this
Yes,
point. So
it is.
yeah, I
It's
mean,
very, very clear.
yes, there's no
How,
question
how,
about it.
how do you go about this? Is probably one that I've asked a few people too. How do you go about talking to an orthopedic surgeon who's really resistant to open chain? What have you come up with a strategy yet on how to, yeah, I guess not show them the light or show them the way, but probably open up a conversation that open chain's actually not as harmful as what you may have been trained yourself. I still haven't come up with the perfect way to address it. But yeah, would interested to hear your thoughts if you've come across stuff in the past.
For me, the ones I've been able to talk to about it are ones that I had a relationship with already.
Yeah.
And typically they didn't hear from me much. So, so if I reached out to them, I was more so just kind of asking questions.
Yeah.
I'm curious why you feel this way. Would you be receptive to changing your mind if I maybe sent you a few papers on this? And
Yeah.
ultimately it's their patients, and it's Mick, I'm sure you can appreciate this. I've had physicians say specifically, don't do anything on a wobble board because they had like one injury where somebody fell off and broke their ankle. So no wobble boards ever, and or whatever the case may be. Like they have one failure because of one episode of something where somebody did something wrong, so you can never do it again. But I'm
Yeah.
not a surgeon, so I don't have to have those discussions, I guess. So
Yeah.
I I think that the best thing to do in my mind in those situations is just try and have a conversation, but it's hard to have those conversations if you haven't built a relationship. So going back with a patient to their doctor appointment, particularly if you don't know them, or maybe if it's a physician you want to see more of their patients. I don't know what it's like in Australia, but good luck getting past the front desk for the most part. When you go to the office, right? So
Yeah.
I think building a relationship first, building that trust, that you have a track record is going to help too, which will open the door to conversation, I think.
Yeah, no, it's definitely not a quick fix. And after hearing your response and a few others, it's like the same messages are coming through. It's establishing that relationship with the surgeon, asking questions, going to meetings, going to go along with their patient, go along with their patient to their follow-up appointments, maybe going to watch them perform surgery. Um, Kind of get in their world and in their space rather than kind of flood their inbox
Yeah.
with spam
I-
about open
I've
chain
dropped off art.
extensions.
I've dropped off articles by hand and
Yeah,
kind of passive aggressive. Like, here's a couple articles I thought you might have interest in. So, so
throw them through
that.
the window.
Yeah, exactly. Right. So I mean, that helped. But again, if you're giving information, right, if you're providing some value, you're not just being a blowhard. There's some. I think you can maybe start chipping away at those walls.
Yep, yep. No, it's definitely a long game with this one. Definitely not a short game. So, no, very good. Well, moving on to the next phase beyond that early phase, and now we're moving into some strength and hypertrophy building. Um, yeah. I guess, do you have kind of loading parameters that you kind of work with that you find works really best? I really found the Welling paper from 2019 to be really helpful for me to be comfortable with adding some nice, happy, sensible loading where just according to the American College Sports Medicine guidelines, if you want to build strength in an adult, these are our sets and rep regimes, and this is how we're going to build them up over time. Like, how do you sort of go about that, and how do we try to avoid this underloading, I guess, problem that we're seeing in our
It's
ACLs
a
at the
gr
moment?
It's a great question. It's multi-layered based on who's in front of you, as always. And I think the first question you have to ask in these cases is what's their training history or training age? Like, is this somebody that's never lifted a weight in their life? So doesn't even understand an RPE scale? Or is this someone that has trained and lifted before and knows what a real effort feels like? So the most basic thing for me is start with an easy, medium, hard. And when you're loading people, you say, I want you to be in the medium or medium hard range, and I typically start with 30% of body weight.
Yep.
So if I'm on the leg press, if they weigh 200 pounds, I'm gonna start with 60 pounds because I use allometric scaling a lot for things like this or percentage of body weight. So we'll start there, work our way up. What's your number? And then after that, it's you look for those effort cues. So
Yep.
I did this I taught last weekend at a course in Minneapolis, Minnesota, and I made everybody show me their workout face, like they're when they're really maxing out, like show me your workout face. I showed mine, like is there a are they showing that they're working hard? Do they put the weight down and there's like a catching of the breath?
Yep.
Do you really see that there's some effort in performing the exercise? And it might mean you have to change the weight 3 or 4 times before you get to that work weight.
Yep.
Uh, RPE would be next, but they have to have a familiarity with, okay, if a 0 is just you and I talking, and a
Yep.
10 is your maximum effort, like trying to pick up a car, that's your
Yep.
10, right? I want you a 6 or a 7 or whatever number it is that you want. And they should have a feel that that's about a 4. Okay, well, I might go up another 20 pounds, and then if I'm in the rep range that I want them in, that's where I'll go. Things like
Nice.
reps in reserve is a concept where the idea that you have one or two, if the target set is 8 reps, the reps in reserve would be no more than 2. So your set should end at 10 at failure, right? And if it doesn't, then you have to go up. If it's too much, you have to go down. So I think those, and that's probably more of a trained athlete though, because they're going to have an idea like how many
Yeah.
more they really have left in the tank. The untrained don't quite have that compass yet. So
Yep.
for me, I would say those are you could always anchor to failure if you're trying to establish a weight, particularly if you don't have a lot of weights.
Yep.
Uh, yeah, I'd say those are probably the best ways to go about it. If you do like an open chain exercise, you could always do as a percentage of force they put out, like in a handheld dynamometer. Like that's another
Yep.
way to kind of get an estimate of their weight. If you have any kind of you could do a 10 RM and do a 1 repetition max estimate from. I mean, there's lots and lots of ways to do it, but I try to start with the most basic. But because we aren't doing a good job in those medium phases, we're guessing a weight to put on.
Yep.
And I say this all the time when I teach. I'll say I'm going to teach this weekend in Michigan. Why give them? And sorry if you've heard this before, anybody that's heard me speak, but it's there's so much truth in it. Why would you have them lift in 3 weeks what they can lift today?
Yes.
And yeah, assuming if all other boxes are checked, they're not hurting, technique is good, mobility is good, all those things. Why wouldn't we? I guess is the
Yeah.
point.
Exactly
I
right.
hope that
No.
wasn't too long-winded, but it's
No, no, no. Oh, that's no, no, that's brilliant, and I love those practical tips too. Once again, because I think a lot of like younger, greener physios who are maybe 0 to 5 years out, who don't have like a background in strength and conditioning or personal training, or have got an exercise science degree leading into physio. Um, yeah, like the basic strength and conditioning that we get taught at physio school is quite small. So, the whole 3 sets of 10 thing is a real thing and a real problem that we see carry on. So my challenge to that is I don't mind 3 lots of 10, but as long as you're getting close to like a high effort, there's nothing wrong with 3 sets of 10. If you're a trained athlete and we're looking to get some hypertrophy back in their system, in their legs. And if you're getting close, if you're getting to 10 and feeling like you got, 1 left in the tank or 2 left in the tank, or 10 reps is your failure point, there's nothing wrong with that. That's a good program. But if you're getting to 10 and you're only doing 10 because, or the patient's only doing 10 because that's what you're written down, even though the person could clearly push on and do 30 reps, you're kind of wasting their time and your own time. So,
You're right.
yeah. So look, there's a time and a place for that kind of stuff. Yeah, but I love those 3 examples there,
And that
of
does
how,
happen, that does happen where you do the 10, like the patient says, well, that's a 6. And then they do the
yeah,
10 reps, and then they're like, should I keep going? Like you can keep going, and then so they do another 10. Well, don't count that first set. Like
yeah,
that's not your first 3 of the 10. You have
yeah,
to establish what 10 truly is. Now we start counting reps. So don't
yeah.
waste reps. It's just imperative that we don't do that.
Yeah, and rest too. Like I think that's the other thing too. Like if we're going to, you know, ask someone to go to a higher intensity, say like a 6 out of 10 intensity of RPE, or you get them 1 or 2 reps in it like that. By the time they finish their set and they're close to failure, they really should be hanging out for a 2 minute rest, maybe three
For
minute
sure.
rest. Yeah,
No
like if you
question.
like you finish your set of 10 and you could just back up straight away after a 30-second rest, like. I'd argue that we're probably not challenging them enough to create a stimulus, to create that tissue breakdown, to create hypertrophy. So we need to, be pushing to the point where they need rest. But for some people, as you mentioned before, like if they're untrained and they're unfamiliar, it's going to take a longer process for them to get trained, and you're going to have to word them up and say, look, some of this stuff's going to make you feel uncomfortable. You're going to get this post
Right.
exercise. You're going to feel pretty crappy and tired often for the first week or two, but look, the great things will come from that, and you'll have more fun stuff to be able to enjoy because you're now stronger and more tolerant, so you can enjoy the fun stuff more. So,
Right.
yeah, yeah, but underloadings are a big problem. But we're certainly not overloading. They end up being overloaded because we underloaded them for too long is often is the problem.
Yeah. And then they go
Yep,
back to a sport that is overloading them,
yep,
right? So we haven't prepared them enough. There's so much talk these days. I'm not sure what it's like in Australia, but here about load management. We're not doing enough for load preparation,
yes,
so that's why it's so important that we do it in rehab and in therapy. Because if we don't, we're sending them out, we're sending them to the wolves, right? And it's not going to go well.
yeah. It's a perfect. I've heard Tim Gabbett, and I think you and Tim got together for a paper a few years ago. But Tim often highlights the concept of the chronic rehabber, and an ACL athlete's not necessarily a chronic rehabber so much, but they are often severely underloaded for a big chunk of time. Like by the time they have their injury, often through their rehab process before an operation, then the 3 to 5 months it takes for them to get to a point where they can run and jump comfortably again, depending on the procedures taken. It could be well and truly over 6 months before they've done any kind of decent cardiovascular on feet work. So these people, when you reload them again, we got to make sure we've got the work done. Otherwise, we're going to run this really crappy cycle of overload, stress, and pain and swelling, and kind of going backwards and forwards all the way through their journey. So that first, 3 post-op months is integral to their future success through middle and late stages.
You have to build a base. There has to be a foundation there. And if you don't have the work capacity base, and if you don't have uh, they can tolerate doing the work,
Yeah,
it's hard to scale it up when they don't have a base, right? And
yeah,
Mick, you know the research. What are I mean, I'm broadly speaking here, but what are the two groups of people that re-tear? One group had no business being out there in the first place.
yeah,
The other group spiked their activity too fast.
yeah,
They did well in therapy, and those we see those people, the unicorns that really fly, but then they
yeah,
get cut loose to high velocity, high decel multiple times for a game, and they haven't conditioned their knee to tolerate that over time.
yeah, exactly right. Um, Onto like a trickier question about these time-based protocols, and you and I probably once again sing from the same hymn sheet about criteria-driven rehab rather than sticking to these arbitrary timelines. How do you go dealing with a patient that's been told by their surgeon that they're cleared to return back to sport at 6 months, yet their objective testing is not 6 months? Yeah, like they're not ready at 6 months or even running. How do you kind of, I guess, balance out that probably disappointment that you get from yeah,
Yeah, honestly, that would have started a long time ago. Actually, my first visit is a lot of talking and education, and I
yeah.
lay out those criteria ahead of time, and I also tell them that that's probably going to happen. That
Yes.
the doctor's going to clear them before I will, and I also say that understand that they medically clear you. Your X-rays look good, the graft is stable, your knee is happy, there's no infection, blah blah blah, but I physically clear you, and then well, he cleared me. I go, but did he watch you run? Did he watch you jump? Did he watch you do any hopping in the clinic? Well, how does he know other than what the calendar says? I mean, you could be if he didn't watch you, you could be a disaster, right? So, and I said, I always say we've talked about this. Remember, this is the criteria, and this is the reason why the criteria is what it is. And ultimately, Mick, as you know, they don't have to take your advice. They could say you're a charlatan or whatever. But hopefully by that point, you will have built up the trust, and they'll see that you'll have done serial testing, that it's improved over time, and that you're approaching that point where we can start doing those things. But yeah, that's a real challenge. I've worked with some locally here that we really have to battle that. And
Yep.
the struggle is real. Let's put it that way.
Yeah. I like how you frame it up early. That's a really good tip as well because it just sort of really leaves no surprises. And because I think that's part of that rapport building and I guess developing that relationship with your patient over time is that you really set out once you meet them for their first post-op visit. It's hard to sort of give them every bit of information at that first session, but it's important that you kind of start addressing that as early as possible.
Yeah.
And it might mean if you get a good window of time, pre-operatively would probably be a better time to be talking about that and kind of really lay
Right.
that foundation early. Some people you won't meet till, after, a week post-op and, they've already sort of started to hear a few things along the way. So, but as early as possible without overloading them when they're already taking in so much. But it has to happen early to set the scene of what the
Mhm.
next 12 months look like. So, um,
Yeah, no, nobody likes surprises, right? So the more you can lay down the foundation and the expectations early that this is what's going to happen, then there's no surprises.
yeah,
That helps out. The other two stats that I use always is 30% re-tear within the first 2 years. And that, from Claire Ardern's work, for every month we wait after 6 months, your risk of re-tear goes down almost 25%. So if we can stretch this to the 9 or 10 month range, your risk of re-tear goes down almost 100%. And that's one that always, like, you see the the eyes get a little bigger, and incidentally, that's about what time it takes to get the muscle strength back, right? So, shocking that the re-tear rates go when you get the strength levels up, right? So, those are the main things I'm doing in those early phases, whether I see them pre-op or if I see them in that first visit post-op, that we talk about right then, so they have 6 months plus to marinate on it.
Yeah, exactly. Yeah, unbelievable. It is. It's a long time, and I think that's probably the challenge for most people. They look at other injuries and think, "Why does ACL take so long?" It's like, well, it is. It still boggles me, But it's that really, it's the joint injury, it's the muscle inhibition, it's the taking the harvest side, it's the deloading. Like it's a
Yeah.
massive insult, And some people will have to go non-weight bearing or partial weight bearing, which will kind of throw out their whole system. So it's a massive insult to the knee and to that whole entire system of the lower limbs where it takes a long time to recalibrate. And even
Yeah.
the best athletes who get 24 hours a day, best physical therapy care, sports medicine care, all the best, strength and conditioning coaches still take the best part of 9 months to get back to professional sport. So who are we to sort of judge a non-professional athlete, or who are we to try and sell this, accelerated rehab plan to a non-professional high school athlete who doesn't have the same kind
Mhm.
of support system like that? That's where I think
Yeah.
I think the conversation probably needs to come back to a 12-month mark for those in the non-professional settings, but that's just me. Yeah, but anyway, we'll
Yeah, and it always comes up to, well, my friend, ran
yeah,
at, this time, or my friend did this at this time, or they did it a month before me. And I'm like, isn't your friend on a revision? Like, you know what I mean? Because, like, like, didn't he re-tear? Like, so it's like you can't, but I also say that it's another one I say, don't compare yourself to other people.
yeah,
You're different sport, different ages, different gender. They may have you may have a meniscus repair, they may not have. Like, don't do that to yourself. You're going to drive yourself crazy. You're an individual. We'll treat you as an individual, and just stick to the process.
yeah, yeah. The competitiveness is something we need to probably, between themselves, between their siblings, between their individuals, their friends, like that competitive and comparison kind of stuff. Yeah, that's one thing I try to knock on the head as early as possible as well. Like, don't compare yourself to an elite athlete who does this for their full-time job, nor should you compare to your friends or family as well. So some nice messages there, Dan. Thank you. What about return to sport? You've sort of touched on a few things that you've got a few clinical measures up your sleeve and in your bag of tricks. What is, I guess, what are your non-negotiable kind of
Yeah.
tests, or in terms of strength tests, in terms of function? If you could have two or three things that you routinely do because they provide you the most amount of information, but you might have a list of six that if they don't get done, it probably doesn't matter so much. Like, where do you sit, and what are your
Yeah.
kind of non-negotiables?
Uh, Definitely a strength test, without question. Quads and hamstrings, certainly proximal hip is probably, a secondary, but quad and hamstrings are very important. Single leg vertical jump has become a staple. We all know the data. If you don't, it's out there that the hop tests really do hide the quad deficits because you can use hip or ankle strategy, and they just don't tell us as much as they think. You can't lie so much. You can't hide it as much on the single leg vertical jump, so that's a non-negotiable for me as well. Uh, we have the luxury of having force plates. So a drop vertical jump on that as well, and a counter movement jump too. Because it's amazing how many sports scientists I've talked to. Like, what metrics do you look at on the force plates? And that you can never get a straight answer. But I feel pretty good now that the single leg vertical, the drop vertical, and a counter movement jump. And again, you're like, well, that's great. I don't have force plates. There are apps now. Again, I have no
Yeah,
financial interest, but like the MyJump app is cheap, it's accessible, you can do it anywhere. A lot of those metrics can be addressed there. One other test that I like to do, well, there's the 40 centimeter side hop test.
yeah,
It's a little bit of a frontal plane test. I like that one. And then we also use one where we have 6-inch cones. It's hard to even visualize this, but we have 6-inch cones. They're 18 inches apart. The athlete single leg hops in the medial direction over each cone, and it's timed, and they take 2 trips there and back.
yeah, nice.
Um, yeah, I like that because it's frontal plane, it's reactive. And what we like about that too is that you can kind of see how they react to the ground quickly because it's
Yeah,
timed. And you can they can hear, like, can you hear how hard you land on your involved side? It sounds like you got a 10-year-old on your back. Like,
yeah,
they're not as fleet-footed. And that's kind of one of those tests I feel in those late stages, especially if they think they're more ready than they are. I like that one because it kind of exposes them a little bit.
yeah. So
Uh,
that's a triple medial hop.
and then they reverse course, go back, so it becomes a
Vertical.
lateral hop, and they do it twice, and it's for time.
Yeah, wow, awesome.
So yeah, I've been
That's
doing that for a
stressful.
while.
That's
Um,
that's what I explain to my patients is that you could be great in a horizontal, a vertical, but when I start testing you with a medial hop, that's where your knee's going to really feel because it's that medial direction where you're going to put a bit of imposed demand, and it's going to be that funny feeling. Might even take you back to the moment where you hurt your ACL with that medial cut. So that's a really stressful a knee exam. I really like that one. I might bring it in next week.
Bart Dinganen had a good paper in 2019 about the medial triple hop. We've started to use that. And again, we don't do these on everybody all the time. It's who's in front of us, right?
Mhm.
Um, they have the rotational hop. I haven't done a lot of that one yet. Uh, so anyway, I'm getting off track here of other ones you could do. I know your focus was on what do I specifically do, but again, the non-negotiables, the quad and hamstring strength, the single leg vertical. If you can do a drop vertical somehow, because it
Yeah,
tells us how they react to the ground and all that stretch shortening cycle basically.
yeah,
And then I don't think we can't ignore the ACL return to sport after injury scale. You have to do that because it measures that fear. 20% don't go back out of fear of re-injury, and that is the kinesiophobia piece is hiding, and that's again it's a both and. They do the physical part on the field, but where are they at up here? And that really matters. And I didn't know that enough coming up, and
yeah,
it's really been a game changer in the practice because what they test on that matches what they do, what they're willing to do when you do functional drills and testing.
yes, yeah. Love that. I like how we basically sit with the same tests as well. I've really scaled back a lot of my testing to, I used to do the horizontal four hop test battery. I would measure kind of everything and try to just sort of piece the puzzle. But over the years, I've really sort of narrowed it down to quads and hamstrings, and even sometimes if they haven't had a hamstring graft, I may even kind of if time's precious, I can sort of come back to it another day. But if I had an essential strength test, it would be definitely quads in the clinic because I know regardless of patella tendon or quad tendon, their quads are gonna be shot, and I need to keep track of those, and I want to make sure they're hitting some high numbers. Hamstrings definitely are there, but yeah, single leg horizontal, single leg vertical, single leg react drop, and then counter movement. Same. Are you looking for any particular numbers? Like, are you looking for side to side differences or RSI scores?
Yeah.
Just to
I mean, I just want to see a sub 10% difference on each side. If we're looking at certainly there are metrics for performance where you'd like them to be. But to me, it's a sub 10% difference. And, I always get the question, do you want them symmetrical even though they're going back to an asymmetrical sport? Athletes are asymmetrical anyway. For me, that answer has always been, I want you symmetrical when you leave. I want to let the sport tease out the asymmetry.
Yeah.
And I don't know what, especially if I don't have a baseline, like if I had no testing beforehand, like maybe they had an inherent deficit anyway, and they're back to normal now. I don't care. I'm getting you back to even, and let the sport over time, let those asymmetries tease out over time.
Yep, yep, love it. And yeah, agree. Like force plates are nice. They're especially with some of the plates that are available on the market, they can have some really great valuable numbers spat out you pretty quickly. But there's some great apps out there too, which are
There
really
are.
effective. And I think that's where we probably, if you are managing a caseload of ACLs and a reasonable volume, if you don't have any kind of like app-based system or force plates, it's not I wouldn't say it's negligent, but it's probably not getting the best possible service to your patient, and we need to probably be looking at investing a little bit of tech. That's would be my kind of two
Yeah,
cents.
you have to have at least a handheld dynamometer, and there are more affordable options now. You could certainly use a crane scale. If you still can't do that, uh, I love the pistol squat to as low of a box as you can go. Again, that is where the deficits are hiding because of the further you go into flexion, the relative muscular effort of the quads and the glutes increases. So this little 8-inch step down is not doing the trick.
No,
Okay.
no.
It's not nearly high enough. So that's why like I use a 12-inch box pistol squat as a litmus test. Again, that's another one where the athlete's like, whoa, I didn't realize that it's still this hard when they compare it to the other side. So that's a great test in my view. That you just need a 12-inch box. They put their heel on the back of the box. They single leg squat down. A can
Yeah,
even do it. And then,
yes,
what's it look like in 30 seconds? How many reps can they do? I mean, that's a great way to if they can do that with relative symmetry, I
yeah,
would I would say they're going to come really close to passing all their other tests. That's a good test
yeah.
with a limited budget, with limited budget.
Exactly right. I think there's definitely some low tech options here that you can do in the field quite nicely. If you're on the road and you can't take your force plates around, you can just do some quick sort of maintenance checks. Yeah, lots of great tips there. I love that.
Well,
I love
and there was that 8RM knee extension test from 2013 paper that
Yep,
it was very close. It definitely correlated to the dynamometry score, the isokinetic score. So an
yes,
8RM knee extension test is if you have a knee extension machine, you could do an 8RM test.
yep,
So though
beautiful.
you do that and the pistol squat, you didn't spend
Yep,
any money and
yep.
you did a pretty good job doing an open and a closed chain quad test.
Yep, and an ACL RSI. And look, as much as the horizontal hop tests have been rubbish, I still do a single leg hop for distance just to sort of see how they control their land and just that single leg power. Like if you're a tall basketball athlete and or even like someone plays football or soccer, AFL here in Australia, if you're a male and you can hop your height or within 10% of your height, that's a pretty good performance measure there. And if you're a female, if you can get 10 to 20% of your height, there's still solid numbers there that tells me you're in good nick. But of course, to get that isolated quad work is probably just that next layer up, and an 8RM knee extension or an isometric handheld dyno test, obviously gold standard, still isokinetic for a few different reasons, but yeah,
Yeah.
a couple of
I mean, you can still do a good job. I did it for 20. I've only had isokinetics for like the last 5 years, and I've been practicing for 25. So you can still do a good job. You might have to do a few more tests than people that have the toys do, but I still
yeah,
think you could, when you put the body of work of what you're seeing them do in the clinic and what you see on the test, you'll develop that instinct after a while, I promise.
yeah, very good. Speaking of being an experienced clinician for 25 years, you would have seen the pendulum swing a bit over your
Yeah.
career. What do you think? Yeah, looking back, what's one thing that you've seen, or one thing I think we may have sort of talked about it before with open chamber? Is there anything else in
Yeah.
ACL land where, yeah, we've kind of come full circle on, or we've completely changed our ideas 180? What are some of the probably biggest things in ACL land that you've seen?
I would say the biggest one, no, in my mind, no question, is the accelerated rehab from the early 90s.
Yeah,
That was a big deal coming out of an institution in the Midwest in the United States, and the 4 to 6 month discharge. And, when I got out of PT school in 2001, I was determined to get people back in 6 months because it was about my ego and that I could do it. You
yeah,
know, I don't know how many people retore. I don't recall seeing anybody that came back because of that.
yeah,
But without question, I think that the return to play time has extended past 6 months, which I think all of us would agree is a good thing on a number of levels. You're going to have those unicorns that are ready in six. They're, I think, really, truly few and far between, but they do happen.
yeah.
But I think without question, that's probably the one thing where I look back when I was a younger clinician and what we know now, it's like, ugh, that I shouldn't have done that.
Yeah, I agree. Like that, I think, and it leads on to my next question is, maybe some of the mistakes you've experienced, and that would be one of mine. A young person, two people in particular. So like some of the things I wish I could take back was, two young people, two 14-year-olds. They both had allografts. One, arguably, they probably should have had allografts to start with, being so young, and having even then the literature was pretty clear that allografts in young people shouldn't be done. And these kids were non-professionals, went back to soccer at the 9 month mark, and really should have been 12 months plus kind of processes. And both
Yeah.
kids tore, both kids retour within a matter of months. In the one first handful of games, both these kids, I was 3 or 4 years out as being a clinician. But the thing was back then, like, 10 years ago, 12 years ago, there was still this push to get people back to sport, in a faster fashion than probably what we now feel comfortable with. It's okay to be, 9, 12 months post-op, and even crap, like if it takes you 18 months, who gives a shit? Like, that's, you know, like,
Yeah.
yeah,
Well, and then those, I'm sorry, go ahead. Finish your thought. Excuse
yeah,
me.
yeah, I would
I was to
agree.
say that in the allografts, the problem is again, like you, I was seeing them 2, 3 years out, and they were coming. I was just starting to see these, and they felt like Batman. Like,
Yeah,
they didn't have the issues with the quad deficit, and they felt amazing. So,
yeah,
I was treating them like full throttle, like I did an autograft.
yeah,
And again, I don't know what those knees looked like 4 or 5 years down the road if I stretched that graft out like silly putty,
yeah,
So. But I didn't know any better, I do now, but
yeah.
it's what we knew at the time, right? So, but yeah, I would definitely go back and tell my younger self. First off, don't tell your patients to get allografts. Secondly, slow them the heck down if you do get them.
Yeah, yeah, no, very good wise tips there. The thing that I've seen, not that I was around, 30 years ago practicing, but I've certainly seen a resurgence lately of the LET procedure. Are you seeing a little bit more of
Yeah,
that? It's
I'll tell you what,
routinely.
and I'm here for it, man. So
Yeah,
yeah, it's I hope, right now they do it with revisions, chronic ACLs, hypermobilities,
yeah,
those kind of things. I hope it becomes the index procedure where they just do it while they're in there.
yeah,
I think there's enough data now, at least in my view. Certainly, you might get some surgeons who disagree. And maybe it's just because there's still the familiarity bias, I guess. But I'm hoping that they just do it because the results are so impressive after with revisions that why not?
yeah.
And
Well,
yeah,
It's
they
it's
take.
a
Go ahead. Sorry.
it's an insurance policy. It's a nice insurance policy, and
Heck
yeah, look,
yeah.
I'm yes, I have spoken to a couple of surgeons here locally about it, and they do have concerns over just routinely doing it. With their concerns being OA risk of the lateral compartment, which some literature is pointing towards maybe that OA risk is because the tightening up is a bit too much, and that's probably a surgical error as opposed to anything else. Obviously, financial costs being an extra burden to the patient, but then, like the cost of having a second surgery, that
Yeah.
would buffer that.
Yeah.
And then also time under surgery, like, the procedure takes an extra 15 to 20 minutes. Would that kind of, so they're kind of, I guess, a bit of the pushback for the routine use, but I'm seeing more primary ACL reconstructions plus LET being done
Yeah.
in high-risk populations, so young females and hypermobility. So the surgeon
Yes.
will establish that at their consult, and these first timers will get the LET done here a lot more routinely than what I've seen, 5 years previous to that. So it's happening.
Yeah, no, I like it. I did a talk last year in Las Vegas on LETs, and I had to dig into that arthritis piece. And honest, from everything I found, there's a little bit, but I mean the incidence is extremely low. So I'm just not seeing those problems. I mean, they take a little longer to get their terminal flexion. Sometimes they have, at least I don't know about, maybe you're seeing this. They take a little longer to get their terminal flexion. They have some mechanical pain laterally from time to time, some, pinching, things like that. But we can treat that prophylactically, but then they do fine.
Yeah.
So yeah,
Yep.
I like
And
it.
yep, there was a nice systematic review. I was at a conference just 2 weeks ago and had a couple of people present on that from some data at a Gold Coast hospital here in Australia, and they've done a nice amount of work there, and they've sort of found the first 3 to 6 months. So they got a case, I think 700 cases that they've done it. And they also did an additional systematic review from the established work. Basically, the first 3 to 6 months is going to be some pain, more so than not having LAT, but by 6, 9, and 12 months, that pain has kind of reduced back down in that lateral aspect. So yeah, same thing, a bit slower to get the flexion back, maybe a little bit grumpy to start with getting, terminal knee extension in some people too,
Yeah.
and a little bit of pain sensitivity. First 2 or 3 months, a little bit crappy, but 6 months and beyond, it's kind of fair game. And to have a reduction risk of about 50%. Look, if I was to ever have an ACL reconstruction in the future, I'd be asking the surgeon to reinforce it. Let's do it.
Yeah, no question.
Yeah. Well, Dan, you've been wonderful, mate. I'll wrap things up with one final question, mate. Thanks for all your wisdom and expertise. I'm sure our listeners have and watchers have learned a ton,
I
absolute
hope
ton.
so. I hope so.
ton.
The fate of your podcast depends on this. So, any further watching people.
Hey,
So, nope, I didn't. It was
absolutely.
a colossal
This
failure for you, buddy.
this this episode is my make or break. It's absolutely doomsday for me if this tanks. It's
Yeah,
all on you.
yeah.
What's one piece of advice you could give to a new clinician, a new physiotherapist is embarking on their career? But let's talk specifically about ACLs. They meet their first patient for their first ACL patient in their career in the first week of practice. What's one, I guess, clinical tip you can give them to help?
This is always my clinical tip for any young clinician, ACL or not, but be an expert at the basics. Don't overcomplicate this. I don't care if you have the best player in Premier League on your table or a high school uh, athlete that really isn't that athletic but tore their ACL. They all need the same thing. They need extension. They need reduced swelling. They need the pain to go down. They need the quads to function. Progress them along. And then when you do progress them, don't get cute with your exercises. Squats, deadlifts, leg press, hamstring curls. Do the basics well. You don't have to have a circus act with different devices and all those kinds of things. They need strength, they need to build capacity. Do those things well, and your patients will do well.
Love it. Simple, keep it simple, stupid, and it's often just forgotten. It's Everyone goes chases the sexy exercises that sort of take up your YouTube feed and your TikTok videos, but that messaging is beautiful, Dan. Keep it simple, keep it consistent, and do the basics relentlessly well. I love it. Well done. Thank you.
Yeah. Thanks for having me, man. Nice to talk to you. Talking shop. Heck, man, I can go on all day. I love this stuff. So anyway, no,
Yeah,
good to visit with you, and I hope your listeners found it to be valuable and hopefully with some good information.
no doubt they have. No doubt they have. Thank you very much. We'll sign off here to all the ACL hubbers here that have watched this interview. Thanks for joining us. Stay tuned. There's more coming up. We've got more athlete interviews coming up and more ACL experts coming up over the next few months. So stay tuned for the next one. Until then, we'll see you next time.